Welcome to our second and last video on ischemic heart disease. Let's begin. Here is a quick overview of the topics we will be covering in this presentation. They consist of acute coronary syndromes, unstable angina, NSTEMI, and STEMI.
In unstable angina, there remains an imbalance between myocardial oxygen supply and demand. However, the oxygen demand is unchanged while the oxygen supply is decreased, secondary to reduced resting coronary blood flow. This indicates a more significant stenosis of the coronary vessels than in stable angina and possible thrombosis, hemorrhage or plaque rupture leading to total occlusion of coronary vessel. Clinical features of unstable angina include a patient with chronic stable angina that may be experiencing worsening angina in terms of duration, frequency, or severity. Unstable angina can also present as new onset angina, which is severe and worsening over time in nature. Chest pain at rest unrelated to exertion or any factors that increase myocardial oxygen demand is characteristic of unstable angina. Here we see that the workup for unstable angina is similar to that of the prior two diagnoses. Cardiac biomarkers will be negative, ECG will show no ST elevations, cardiac stress test will be positive. The only difference in workup between unstable and stable angina is that in unstable angina, cardiac catheterization may be performed electively, although this is pretty rare in real practice. Cardiac catheterization is an interventional test performed to see if an occlusion in the coronary vessels can be located. This is done fluoroscopically by injecting contrast dye into the coronary vessels and capturing the flow of said dye with an X-ray. We'll now move on to the treatment for unstable angina. Treatment for unstable angina include MONA-BASH with potential elective cardiac catheterization and revascularization. Patients with suspected unstable angina are advanced to an inpatient level of monitoring and care. This is where we begin to treat this essentially the same as a myocardial infarction with the exception of fibrinolysis, as unstable angina is considered an acute coronary syndrome. You may notice that management of unstable angina is similar to that of myocardial infarctions. This makes sense because the pathophysiologic processes are similar in that the myocardial tissues are being thoroughly deprived of much-needed blood flow, and we need to know what we can do to restore appropriate vascular perfusion of said tissues. However, a key difference in management of unstable angina versus MI is in unstable angina, we wouldn't use fibrinolysis. This is due to the fact that unstable angina is more commonly caused by gradual partial occlusion of a coronary vessel, and not a sudden completely occluded vessel by a thrombus in immediate need of removal, such as in the case of an MI. Patients with unstable angina are hospitalized with continuous cardiac monitoring, IV access, and given supplemental oxygen if hypoxic. MONA-BASH is a common mnemonic used to remember the treatments indicated in acute coronary syndromes. This mnemonic stands for morphine, oxygen, nitrates, aspirin and clopidogrel, beta blockers, ACE inhibitors, statins, and heparin. Unstable angina is often treated with cardiac catheterization and PCI as well. A cardiac catheterization will provide a clear image of just how severe the coronary vessel occlusion is and if a stent is needed to be placed in order to protect the patency of the vessel lumen. Why are cardiac enzymes typically not elevated in the case of unstable angina? Typically, cardiac enzyme levels remain too low to be detected in unstable angina simply because the level of ischemia in this condition is not severe enough to cause cardiac muscle cells to release enough enzymes, such as troponin or CKMB, in order to be detected in the bloodstream. Keep in mind, however, unstable angina and NSTEMI may be indistinguishable within the first 12 hours of the presentation of a patient with clinical symptoms of ACS and no ST elevations on ECG. This is because cardiac enzymes can take a while to build up to detectable levels within the blood. Let's say during our initial evaluation of a patient that the patient has symptoms raising the suspicion for ACS and an ECG is negative, but then the cardiac biomarkers come back positive. We then arrive at the diagnosis of NSTEMI. As you can see, the sole difference between the diagnosing NSTEMI and unstable angina is the presence of positive cardiac biomarkers which indicate cardiac tissue damage. Keep in mind, we have only addressed ST elevation in our algorithm for the sake of simplicity. In the event of NSTEMI or potentially any ischemic cardiac etiology, there may be non-specific ECG changes such as ST depression, T-wave inversion, or pathologic Q waves. Do not be thrown off by these findings. As a quick reminder, a transmural infarction will lead to ST segment elevation, while a subendocardial infarction will lead to ST segment depression. The pathophysiologic cause of non-ST elevation myocardial infarction, aka NSTEMI, is usually due to the rupture of an atherosclerotic plaque, which leads to thrombosis formation and nearly complete or completely occluded coronary arteries. The clinical features of NSTEMI can include severe crushing chest pain that typically lasts longer than 20 minutes.
This pain can radiate to the jaw, back, or arms, mostly on the left side. Epigastric discomfort presents in up to 15% of cases. NSTEMI can also be associated with dyspnea, diaphoresis, weakness, nausea, vomiting, a sense of impending doom, and syncope. Our diagnostic process remains similar to all the previous ischemic etiologies. However, in this case, ECG will not display ST elevations, and cardiac biomarkers are typically positive, indicating myocardial cellular damage. Also, in the situation of NSTEMI, an urgent cardiac catheterization is required in certain circumstances, which we will cover in the treatment slides. Now, moving on to the treatment of NSTEMI. The main treatment for NSTEMI include Mona-Bash and possible urgent cardiac catheterization. And we just saw on our algorithm, NSTEMI is treated with Mona-Bash medications at an inpatient level of care. Don't forget the difference in treatment between unstable angina and NSTEMI or STEMI is need for fibrinolysis. This takes the form medically as tissue plasminogen activator, also known as TPA, or the preferred treatment interventionally with cardiac catheterization and PCI or CABG. However, TPA is not recommended in setting of NSTEMI, and urgent revascularization via cardiac catheterization and PCI is recommended only in the following scenarios. These scenarios include the following. If the patient is hemodynamically unstable, has severe LV dysfunction or heart failure, has persistent angina at rest despite medical therapy, has new or worsening mitral regurgitation or ventricular septal defect, and finally, if they have sustained ventricular arrhythmias. Any of these 5 situations signify a scenario in which urgent surgical treatment of NSTEMI has shown significant advantages over medical therapies alone due to their high risk of adverse cardiovascular event in the short term. Which patient populations are atypical presentations? Epigastric pain, abnormal duration, isolated refer pain of neck or jaw. Of NSTEMI, most common in. If you're thinking women, elderly, and diabetic patients, you are correct. Looking back at our algorithm, if obvious ST elevations are present at initial evaluation, then STEMI is most likely. The pathophysiologic cause of ST elevation myocardial infarction, aka STEMI, is very similar to that of NSTEMI, usually due to the rupture of an atherosclerotic plaque which leads to thrombosis formation, completely occluded coronary arteries. Clinically, STEMI presents in an indistinguishable manner from NSTEMI, with all the same signs and symptoms. The best diagnostic workup of STEMI is similar to that of NSTEMI, however, as the name suggests. On ECG, ST elevations will be present. This is cause for emergency cardiac catheterization. Moving on to treatment for STEMI. STEMI calls for an emergent trip to the cath lab for cardiac catheterization and revascularization with PCI or CABG, as well as Mona-Bash. What could cause abdominal pain, blue discoloration of the distal end of the great toe on the left foot, an increased creatinine, and a mottled purple net-like rash after cardiac catheterization? If you are thinking cholesterol embolism, you are correct. Remember, no invasive procedure is free from potential complications. In this case, a cardiac catheterization can disrupt cholesterol plaques, which can then disassemble through the systemic circulation and cause partial or total arterial occlusion. As you can see, Mona-Bash is still an important part of treatment for a STEMI. The main difference between management of NSTEMI and STEMI is the emergent need for fibrinolysis and cardiac catheterization. TPA, such as tenecteplase or alteplase, should be given only in instances when patient arrival to cardiac cath PCI time, referred to as door to balloon time, is estimated to take greater than 120 minutes and the symptom onset was within 12 hours. Otherwise, PCI or CABG is preferred, and we'll talk about how to select which interventional therapy on the next slide. Keep in mind, nitroglycerin is contraindicated in cases of right-sided infarctions because it could reduce preload and exacerbate any already existing systolic dysfunction in the ischemic right ventricle, further worsening cardiac output. Let's talk about choosing between CABG and PCI for revascularization. If cardiac catheterization reveals a left main artery occlusion or 3 or more vessel involvement, then coronary artery bypass graft, CABG, is indicated. CABG is also indicated in the setting of failed PCI treatment. If catheterization reveals 1 to 2 vessel disease, then percutaneous coronary intervention, also known as coronary angioplasty, is preferred, with door-to-balloon time of less than 90 minutes. Keep in mind, if PCI is performed and a coronary stent is placed, then follow-up medical therapy is indicated. For a drug-eluting stent, dual antiplatelet therapy, aspirin and clopidogrel, should be continued for 1 year, and if bare metal stent is used, then these medications are indicated for at least a month. There are a few treatment caveats and contraindications to keep in mind in the management of ischemic heart disease. These include the fact that unfractionated heparin is preferred in the setting of advanced chronic kidney disease, defined as a GFR less than 30 or creatinine greater than 3.5. Also, do not use ACE inhibitors in the following scenarios: pregnancy, due to its teratogenic effects, previous cough, angioedema on ACE-ARB, to avoid potential adverse reactions. AKI, bilateral renal artery stenosis, or CKD, with creatinine of greater than 3.5, as they can worsen kidney function. SBP, less than 90, or potassium greater than 5, as they will lower blood pressure and can cause further hyperkalemia, respectively. So as you can see here, starting from the top box, we then move to ask ourselves, is this patient hemodynamically stable? The answer is yes. So we can move down the algorithm to our initial workup. While all of these tests are possibly useful, the best initial test would be ECG. A 75-year-old man presents to the emergency department due to upper abdominal pain for the past 30 minutes. His past medical history is significant for poorly controlled type 2 diabetes mellitus and hypertension. He has been smoking 2 packs of cigarettes per day for the past 50 years. His vital signs include a temperature of 36 degrees Celsius, a blood pressure of 155/95, heart rate of 78, and respiratory rate of 19. The physical exam reveals intensive perspiration and epigastric pain without positional variation or precordial tenderness. ECG shows 3 mm ST segment elevation in leads 2, 3, and a VF. Cardiac troponin 1 is negative. Which of the following is the best next step to definitively diagnose this patient's current condition? A. Echocardiography, B. Arterial blood gases, C. Cardiac catheterization, or D. Cardiac stress test. This elderly man presents with upper abdominal pain for the past 30 minutes. His past medical history is significant for poorly controlled type 2 diabetes mellitus and hypertension. He's been smoking 2 packs of cigarettes per day for the past 50 years. His comorbidities and lifestyle habits predispose him to atherosclerotic vascular disease. The physical exam reveals intensive perspiration and the epigastric pain without positional variation or precordial tenderness. These findings suggest acute coronary syndrome. ECG shows 3 mm ST segment elevation in leads 2, 3, and AVF. These findings indicate an acute inferior STEMI due to right coronary artery thrombosis. However, cardiac troponin 1 is negative. It's worth noting that initially negative troponins should not make one exclude NSTEMI or STEMI because troponins take time to increase. Since the pretest probability of myocardial infarction is high in this patient, the best next step to definitively diagnose him is cardiac catheterization. In patients with myocardial infarction, the cardiac catheterization typically shows an acute occlusion of the coronary artery, along with regional wall motion abnormalities like myocardial stunning, so correct answer is option C. Here's a slide reminding us of the diagnostic workup of STEMI. Pause the video and take a moment to consider the slide again. Let's discuss why other options are incorrect. Option A and B are incorrect because although echocardiography and arterial blood gases are usually done in patient with suspected myocardial infarction, they cannot definitively diagnose acute coronary syndrome. Finally, option D is incorrect because cardiac stress test is used to screen the patients for stable angina. However, it is not used in patients with suspected acute coronary syndrome because a cardiac stress test can exacerbate the patient's symptoms. Additionally, even if this particular patient had a negative stress test, it would not make us confidently exclude the acute coronary syndrome. Therefore, he requires urgent cardiac catheterization. And that concludes our lecture on acute coronary syndromes.